When your body's own defense system gets confused and starts attacking your nerves, it can be a scary and bewildering experience. Basic idea behind two conditions: Guillain-Barré syndrome, GBS, chronic inflammatory demyelinating polyneuropathy, CIDP. At a glance, they can look very similar: immune system damaging the peripheral nerves. This damage can lead to weakness, tingling, numbness, making everyday tasks incredibly difficult. Telling them apart is crucial for getting the right care at the right time. Let's break them down into simple terms. Nerves like electrical wires. Myelin sheath, as the plastic insulation immune system attacks and strips away this insulation. When myelin is damaged, nerve signals slow or stop, which causes the physical symptoms people experience. One of the most significant clues that helps doctors distinguish between GBS and CIDP is how quickly the symptoms start and progress. This is what we call the onset. Guillain-Barré syndrome is famous for its rapid and dramatic beginning. Most people who develop GBS find that their symptoms appear and worsen over a very short period, typically from just a few days up to 4 weeks. This swift progression is a hallmark of the condition. It is not something that slowly creeps up on you over many months. It arrives with an unmistakable urgency that often leads people to seek emergency medical care. GBS frequently follows another illness. About 2/3 of people with GBS had an infection in the weeks before their nerve symptoms started. This could be a respiratory infection like the flu or a bad cold, or a gastrointestinal bug, like food poisoning from bacteria such as Campylobacter jejuni. The theory is that the immune system gears up to fight the infection. So, if you suddenly develop weakness after being sick, it's a major red flag for GBS. CIDP, on the other hand, tells a much slower story. Its name gives it away: chronic. This means the symptoms develop gradually over a much longer period. For a diagnosis of CIDP, the symptoms must have been progressing for at least 8 weeks. For many, the timeline is even longer, with weakness and sensory changes slowly building over several months or even years. This gradual onset can sometimes make it harder to notice at first. A person might just feel a bit more tired or clumsy, attributing it to aging or being out of shape, until the symptoms become too significant to ignore. Unlike GBS, CIDP is not typically linked to a recent infection. It is a long-term condition that can follow different patterns. Some people experience a slow, steady decline in function. Others may have a relapsing remitting course, where they experience flare-ups of symptoms, followed by periods of partial or full recovery, only for the symptoms to return again later. This stop-and-start progression is very different from the single, acute episode seen in most cases of GBS. While both GBS and CIDP cause weakness. Sensory changes. There are subtle but important differences in how these symptoms present. In both conditions, people often experience symmetrical weakness, meaning it affects both sides of the body relatively equally. This weakness typically starts in the legs, can move upwards to the arms, and even the face. This is known as ascending paralysis. You might first notice trouble climbing stairs, getting up from a chair, then later find it hard to lift your arms or grip objects. Tingling, pins and needles, numbness are also very common. However, the speed and severity can point toward one condition over the other. With Guillain-Barré syndrome, the progression is fast. The weakness can escalate from mild difficulty walking to complete paralysis of the legs within days. In severe cases, breathing muscles can be affected, requiring a ventilator. Facial weakness in GBS can cause trouble speaking, making facial expressions. Many people with GBS report significant pain, deep muscle aches, cramps, especially in the back and legs. In contrast, CIDP tends to show a slow loss of function. Progression over 8 weeks or more gives the person more time to adapt. Balance problems are common in CIDP. Slow worsening weakness and loss of sensation in the feet make it hard to feel where the ground is. Pain can occur in CIDP, but is generally less prominent than in GBS. CIDP symptoms are a slow erosion of ability rather than a sudden collapse. Let's look at a side-by-side example. Imagine 2 people, Sarah and Tom. Sarah gets a stomach bug and recovers. 2 weeks later, her feet start tingling. and by the end of the week her legs are so weak she can barely stand. This rapid onset after an infection points strongly toward GBS. Now, consider Tom. Over the last 3 months he's been tripping more often. His hands feel clumsy when he tries to button his shirt. His doctor initially thought it was just fatigue. When a doctor suspects GBS or CIDP, they will not rely on symptoms alone. They will use a series of tests to confirm the diagnosis. They will use a series of tests to rule out other conditions. They will use a series of tests to pinpoint the nature of the nerve damage. One of the most important tools is nerve conduction studies and electromyography. The NCS involves placing small electrodes on the skin over your nerves and using tiny electrical shocks to measure how fast and strong the nerve signals are traveling. The EMG uses a very thin needle electrode inserted into a muscle to record its electrical activity. In both GBS and CIDP, these tests will typically show signs of demyelination, that is, damage to the protective myelin sheath around the nerves. This damage causes the nerve signals to slow down significantly. Think of it like a frayed internet cable that makes your connection slow and unreliable. However, the timing of these tests can be revealing. In GBS, the changes on the nerve conduction studies might not be obvious in the first week, but will become clear after that. In CIDP, because it is a chronic process, the evidence of demyelination will be present and can be tracked over time to monitor the disease's progression or response to treatment. Another key diagnostic procedure is a lumbar puncture, also known as a spinal tap. This involves carefully inserting a needle into the lower back to collect a small sample of cerebrospinal fluid, the clear liquid that surrounds the brain and spinal cord. In both GBS and CIDP, a classic finding is a high level of protein without a high number of white blood cells. This is called albuminocytologic dissociation. This elevated protein suggests that the nerve roots are inflamed and leaking protein into the CSF, but the absence of infection-fighting white blood cells helps rule out conditions like meningitis. While both conditions can show this protein increase, again, timing is key. In GBS, the protein level in the CSF may be normal in the first few days of symptoms and typically only rises after about a week. In CIDP, the high protein level is a more constant finding. Doctors may also use blood tests to look for specific antibodies to rule out other causes of neuropathy like vitamin deficiencies or diabetes. Since both GBS and CIDP are caused by an overactive immune system attacking the nerves, the main goal of treatment is to calm this attack and reduce the inflammation. The primary treatments for both conditions are quite similar and powerful. Intravenous immunoglobulin plasma exchange. IVIG involves infusing a solution of antibodies, collected from thousands of healthy blood donors, directly into a vein. These donated antibodies are thought to work by blocking the harmful antibodies that are attacking the nerves, effectively telling the immune system to stand down. Plasma exchange is a more mechanical process. It involves removing blood from the body using a machine to separate the liquid part of the blood, called plasma, from the blood cells. The plasma contains the damaging antibodies, so it is discarded. The patient's blood cells are then mixed with a plasma substitute and returned to the body. Essentially, it is like an oil change for your blood, removing the bad stuff. Both IVIG and plasma exchange have been shown to be equally effective in speeding up recovery in GBS and controlling symptoms in CIDP. The choice between them often depends on the patient's overall health and hospital resources. For Guillain-Barré syndrome, these treatments are typically given as a short course in the hospital during the acute phase of the illness. The goal is to halt the immune attack and shorten the time to recovery. One treatment that is notably not effective for GBS is corticosteroids, like prednisone. Studies have shown that steroids do not help and may even cause harm in GBS. Once the initial treatment is complete, the focus shifts to supportive care and rehabilitation to help the body heal. In contrast, treatment for CIDP is a long-term affair. While IVIG and plasma exchange are also first-line choices, corticosteroids are a very common and effective treatment for CIDP. Many people with CIDP will start on a high dose of prednisone, which is then slowly tapered down over time. Because CIDP is chronic, many patients require ongoing maintenance therapy for months or even years to keep the symptoms under control and prevent relapses. This might mean regular IVIG infusions every few weeks, or if first-line treatments are not enough, doctors may use other immunosuppressant drugs to manage the condition long-term. Imagine two different storms approaching: a sudden, intense hurricane, like GBS, persistent, long-lasting rainstorms, like CIDP. Knowing which storm helps doctors protect your nerves and help you regain strength and function as quickly and safely as possible. This guide will clarify the key differences. We will cover how each condition starts the symptoms. You might notice the tests doctors use to diagnose them and the different approaches to treatment and recovery. We will use real-life examples to make these concepts easier to grasp. Demystify these conditions. Reduce anxiety, empower you to talk with your healthcare team. Get to a diagnosis faster, so the right help can begin, The long-term outlook or prognosis for GBS and CIDP is as different as their onset. For Guillain-Barré syndrome, although the acute phase can be severe and life-threatening, the outlook is generally positive. Recovery is the expectation. After the symptoms reach their peak, which usually happens within 4 weeks, most people begin a gradual process of improvement. The nerves have a remarkable ability to heal and regenerate their myelin coating. Early treatment with IVIG or plasma exchange can significantly shorten the recovery period and improve the overall outcome for many individuals. However, recovery from GBS is not always complete. While many people return to their normal lives, a significant minority are left with some lingering problems. This could be persistent weakness, numbness, fatigue that affects their daily activities. A smaller percentage may have more severe permanent disabilities. The journey back can be long and requires intensive physical therapy, occupational therapy to rebuild strength, coordination, independence. The good news is that GBS is typically a one-time event. Relapses are very rare, so once a person recovers, they usually do not have to worry about it coming back. The outlook for CIDP is much more variable because it is a chronic illness. The course of the disease can differ greatly from person to person. Some people may have a single episode and then go into a long-term remission after treatment. Others will have a relapsing remitting pattern, with periods of worsening symptoms followed by recovery. Still others may experience a slow but steady progression of the disease over many years. Because it is a long-lasting condition, the goal of treatment is not necessarily a cure, but rather to manage symptoms, prevent relapses, minimize long-term nerve damage. Living with CIDP often means adapting to a new normal. It may involve ongoing maintenance treatments, regular doctor visits, continuous commitment to rehabilitation to maintain function. The good news is that with early diagnosis and consistent treatment, most people with CIDP can prevent severe disability. The key is to work closely with a neurologist to find the right long-term treatment strategy. Unlike GBS, where the storm passes, living with CIDP is more like learning to navigate a sea that will always have the potential for rough weather. Knowing when to see a doctor for symptoms of weakness or numbness is incredibly important. The urgency depends on how quickly those symptoms are changing. If you experience weakness that starts suddenly and gets worse over hours or days, you should seek medical attention immediately. This is especially true if the weakness is moving up your body. If you begin to have any trouble with breathing, if you begin to have any trouble with swallowing, if you begin to have any trouble with speaking, these are signs of a medical emergency and could indicate severe GBS. Go to the nearest emergency room without delay, as rapid treatment is essential to prevent serious complications. On the other hand, if you notice a more gradual onset of symptoms, it is still very important to see a doctor, but the situation is typically less of an emergency. If over several weeks or a couple of months you are becoming weaker, your balance is off, or you have persistent tingling or numbness that is slowly spreading, you should schedule an appointment with your primary care physician. They can do an initial evaluation and will likely refer you to a neurologist, a specialist in nerve disorders. Keeping a simple log of your symptoms can be extremely helpful for your doctor. What they are, when they started, how they have changed. The bottom line is this: Guillain-Barré is fast, CIDP is slow. GBS is an acute crisis that often requires hospitalization. CIDP is a chronic condition that requires long-term management. Distinguishing between them quickly is key because the treatment plan and the expectations for recovery are very different. An accurate diagnosis allows doctors to start the right therapy. Short-term, intensive care needed for GBS. Long-term sustained treatment required to control CIDP and prevent lasting nerve damage. Your role is to listen to your body and advocate for yourself. Do not ignore unexplained weakness, numbness, balance problems. While it's easy to dismiss early symptoms as tired or clumsy, they could be the first signs of a serious neurological condition. By seeking help, you take the first and most critical step toward diagnosis and recovery. Remember, you are not alone. Neurologists are experts and can guide you through testing and treatment with care and support, helping you achieve the best possible outcome, no matter the diagnosis. Guillain-Barré is fast. CIDP is slow. Different timelines, different plans, both treatable. Early recognition and the right care make all the difference. If you or a loved one notice these symptoms, reach out to a healthcare professional today.